Welcome to the BC chapter of the Canadian Association of Critical Care Nurses Fall 2023 Innovation Roundtable held on October 19th. Please enjoy Dr. Kimia Ghavami's presentation on the use of TNK in acute ischemic stroke.
Thank you so much, Kimia, for joining us. We're super excited for your presentation. So I think you're able to share your screens.
So hi, everyone. My name's Kimia Ghavami. I don't usually sound like this. I apologize if the voice is a little in and out today. But I'm one of the stroke neurologists here at VGH, and I also sit on the Stroke Services BC as a medical chair. And I'm really excited to kind of present an update to everyone on something that the stroke community internationally has been working towards, and that's switching from TPA to TNK as our primary thrombolytic for acute ischemic stroke. And I think this will be a quick update so that I'll just share some information and then really just, again, leave lots of space for questions as this is going to change practice for a lot of us moving forward. So when we talk about acute ischemic stroke, of course, I'm referring to any arterial blockage that, reduces blood flow in the brain, immediately causing cell death, and restoring blood flow can be achieved by breaking down the clot using a thrombolytic agent. Now, historically, since the 80s, it's always been Alteplase, but now we'll be introducing tenecteplase or TNK as our preferred agent moving forward. So what's the difference between TNK and TPA? So TNK is produced from endogenous TPA, but it's done so with a recombinant DNA. So compared to TPA, it has a higher fibrin specificity, less likelihood to deplete fibrinogen, and most importantly, it has a longer half-life. TNK itself is not a new drug. It's been around for a long, long time, but it was always used in the cardiac MI literature and data, whereas for some reason or another in the 80s, when stroke started first doing thrombolysis trials, they chose TPA. And so that's sort of, even though the drug's been around up until recently, just kind of out of historical reasons, we'd always used Alteplase rather than tenecteplase. So in the last kind of decade or so, many providers and researchers identified that TNK might actually offer many advantages than TPA. And primarily that's just because of some of the factors of TNK, like I mentioned. The half-life means that it doesn't need to be an infusion and it can be a bolus dose. The fact that there's less fibrinogen depletion and that there's more specificity, raised questions as to would the bleeding risk be lower? Would it be more effective? And once we realized that TNK was an alternative, it took some time to find the right dose. And the big take home today is that the dose for acute ischemic stroke is different than the dose that some of you may be familiar with for acute MI. So the dose in acute ischemic stroke is 0.25 milligrams per kilo to a maximum dose of 25 milligrams. That's half of cardiac dosing. And it is important to pay attention when administering the medication that we use the correct dose, because we know that at higher doses, the risk of hemorrhage is actually quite a bit more. So with the dose trials that took place, dose defining trials, I call them, when they were trying out these different doses and ultimately landed at 0.25 as being most effective and safest, we then had a randomized control trial that was actually led in Canada with over 2,000 patients that showed that TNK was as effective as TPA, or specifically from a statistical standpoint, the study was done for a marker we call non-inferiority. And it met that, suggesting that not that it was better than TPA, but it was at least non-inferior, worked as well as TPA. And so with that said, and given some of the administration benefits, timing benefits, and transport benefits, throughout Canada, beginning in 2022, different provinces started to transition to TNK. Internationally, I can share that many sites in the US, Australia, and New Zealand have already switched to TNK. Europe hasn't yet, but it's being reviewed, and Asia also hasn't yet, but again, is being reviewed. And last week, in fact, there was a World Stroke Congress with lots of stroke researchers and clinicians from across the globe all kind of sharing that at their own sites, they're all planning to switch to TNK. In terms of other practical considerations, there actually isn't many differences that we plan to transition. So the criteria for who qualifies for TPA or TNK is the same. Your time windows are the same. The dose is the biggest difference. And again, the administration. So for many of my nursing colleagues, like this will be the big benefit is we don't need to like prime a line or set up a whole pump or anything. You just mix it and push it. And that's it. The other impact is for transport, and especially in BC, where as we often wax and wane in stroke, time is brain. We know that our door in, door out times, which is the time I talk about, when a stroke patient arrives to a primary stroke center, they get their TA, their lysis, and then they get transferred to another center like VGH or Royal Columbian for endovascular thrombectomy. The door in, door out times, the faster we can get someone to an EVT capable center, the much higher likelihood that they're going to have an independent outcome and be able to go home to their families. And so in transitioning from TPA to TNK, one of the big differences and one of the biggest implications for us as a province is that this will help with transport needs. And speaking with many of you who are critical care nurses, for your patients who maybe aren't going anywhere else, so if you work at a center where they're getting lysed and then they're staying and you're taking care of them as their primary team for post-lytic management, it's the same. So monitoring and post-care is the same. Your blood pressure targets are the same. The complication rates, the things you need to watch for are the same. The risk of angioedema is all the same. So in a critical care context, you may not see a big difference as we switch from TPA to TNK, but certainly if you're in an emerge where you're administering the lytic, you'll hopefully see that it's faster and easier to give. And if you've ever been part of the transport of these patients, you'll hopefully also notice that it's a lot faster and you're able to move patients more effectively throughout the province. This guideline recommendation across Canada was formalized in 2022. And so I speak to this because one of the questions we received early on was, if you look under the Health Canada approval for TNK, it's really only currently listed for acute MI. But often in clinical practice, Health Canada approvals will actually lag behind standard of practice. And so we don't actually use Health Canada as our be-all end-all as clinicians, and even from a pharmacy standpoint, but we use these like sort of consensus guidelines. And so the guidelines were formally updated to share that you could administer tenecteplase as an alternative to any instance where you might administer Alteplase or TPA. So we've been working at this pretty steadily for the past year, and it's been a lovely effort between all the different health authorities within BC. The Interior Health Region has kind of been at the head of this, and they've already been using TNK now for a few months, and Interior, Coastal, Fraser, and Northern are all kind of having these discussions as well. So certainly my hope is that, in 6 months from now, everyone in the province will be using it. But as always, it is a bit tricky to get all the health authorities coordinated to do so at the same time. So for you, if you are working in, depending on what health authority you're working in, you may see that your memo for your TNK timeline comes out at a different time. But speaking at least to the coastal health region where I work and where I'm most involved in like the order set development, I can say the order set's been developed and now it's been kind of circulated between all the different hospitals within coastal that this affects to get nursing and ED and pharmacy sign-offs. And we're kind of, by the end of the week, we'll have that. And so then hopefully on CST Cerner and on the pre-printed order sets by the end of the month, we'll see that at least within coastal, everyone is updated. Fraser and Northern and Island are kind of on their own timeline as well. Education is the most important piece because, like I said, it's been a while since, we've had a big update like this for such an acute medical condition. And so we do want everyone to know that, if you hear someone prescribe TNK for a stroke, it wasn't a misstep. They are in fact giving TNK. And then that should also trigger you to internally, make sure that when you're giving the dose, you're giving the correct dosing. And of course, the PPOs all reflect the 0.25 milligram per kilo dose. This should still be double checked as any other high risk medication. It's no different than the TPA. So this is what the dosing table will look like. Some of you, again, who are more familiar with TPA will be used to hearing us kind of talk about a specific dose calculated per weight exactly. So if the patient's 61 kilos, I would have previously said, okay, it's 0.9, times 61. But the nice thing about TNK is that we can actually do these sort of weight bands. So your patient, if they're just like in a category of like 60 to 69.9, they're going to get a set dose, 70 to 79.9. So it's really easy. You're going to basically, as the nurse, drop 2.5, 3, 3.5, 4, 4.5, or 5 mils. For the less than 40 kilo mark, I mean, these are our very, very frail elderly patients. We just say per neurologist because there's a little bit more complexity around the dosing and the risk benefits at that point when someone is so tiny. But for the most part, it will still likely just be dosed at the 0.25 milligrams per kilo. So again, from a practical perspective, when you're reconstituting TNK, you're going to have a 10 ml sterile water syringe, and you're going to draw that up and then inject it into your TNKs. And in this case, you want to gently swirl the contents till everything is dissolved, and it'll be colorless or pale yellow. And then, like I said, you're going to draw it up, and you're going to draw it up as per your dosing table into one of those set mils, either 2.5, 3, 3.5, 4, 4.5, 5. At that point, you can then actually directly inject the medication. Just one note, it should not be given with dextrose containing solution. So in the unlikely circumstance that your patient was running D5 in an IV already before you got to them, then we just want to, clear the IV, flush the IV first. But otherwise, most of the time, these patients, again, they've come in straight as an acute stroke activation. So they've only got a line in for CT-CTA, and then we're going to be giving the TNK right away over 5 seconds as a bolus dose. No pumps needed. So just for a little bit more information, there's a Stroke Services BC position statement, some more educational videos from Alberta Health Services because they were kind of the forefront of getting this going, and then a webinar as well. And that's really all I had to share. So I'd be happy to take any questions if there are any at this time. Thank you.
Thank you, Kimia. That was excellent. We learned a lot from you. Is there anybody that has any questions for
Tammy has a question. That was a really good presentation. My question for you is, I know this is used for stroke patient. Would it be in the future using a PE patient?
So in the future? I don't know actually in the future if it's going to be used for PE, and I'm not sure what group would want to change it. It wasn't that it was more effective than TPA, so I don't see a reason to necessarily switch to using it for PE. It's just that from an operational standpoint for stroke specifically, because it helps to treat faster and it helps with transport, that's why we're switching. So those things don't really apply as much to PE patients, so I don't see why we would necessarily change. The only other thing I'll add is that there's a cost consideration that TNK can be cheaper if we are able to get smaller vials, but the manufacturer hasn't yet made smaller vials. So if they were to make smaller vials, then it would become cheaper. And so then maybe from that reason, the hospital might switch to TNK. But it's not like there's any trial data to show that it's better, and that's why we're switching.
And then my second question for you is, I know we're using it on a stroke patient. Have you ever seen in any case that you used the first dose and it didn't work and then you have to repeat it a second time?
So in terms of administering it, we would never repeat, just like TPA. It's a set dose, so you give it and it works or it doesn't work. And in terms of recanalization rates, it's about 30%. So a lot of the time TPA doesn't work and TNK doesn't work. That's just the nature of stroke treatment, unfortunately. But those patients are the patients that then often, if they have a large vessel occlusion, are getting transferred to an EVT site. And that's again why I say that switching to TNK, we really want people to move quickly, because provincially our times are actually quite slow compared to the national average. Our door in, door out times are slower. Our door to TPA times are slower, and our door to EVT times are slower than many other centers in Canada. And that's for lots of reasons, but one of the reasons we're trying to address is hopefully by switching to TNK, it'll be easier to give. You don't need to deal with a pump. It's not as complicated to mix. You can just give it as a push bolus dose. And for primary stroke centers, your EHS crew might actually be able to stay. So theoretically, your patient comes into emerge, gets a scan, you decide to give the TNK, that crew doesn't actually need a nurse to now accompany them because there's no pump or anything. They can just stay with that patient and take them right away to an EBT center. And that might help speed things up and just get people care faster.
Any other questions for Kimia?
Yeah, I'm just super curious. I don't know if we have anybody from Interior on the line, but you said that Interior has been using it for the last few months. I was wondering if you could share what their experience with it and what impact that might have had on, moving patients as faster and better. But I don't know. Is there anybody from Interior on the line? Tracy?
Yeah, I'm here.
So.
Sorry, I'm just trying to turn everything on. Yeah, so I don't know for sure what the experience has been for our emergency department, but I know from our critical care transport team, this has been a huge, like that was already mentioned, is that the transport time, like to give it and not have to have the continuous infusion and wait for that transport time and who needs to accompany the individual to one of our tertiary sites has been a huge win. I would say the biggest piece was just the educational component. Again, updating our medication monographs, our order sets, and just really socializing it because everybody is so used to the TNK. So it's been, sorry, for TPA. So it's been just a huge education learning curve, but it's been very, very well received. Everyone's so happy, push and done, right? So from a nursing perspective and transport time, it's been very embraced. And this is all like Tam Hruska. We have our stroke CNS. She's wonderful and she hails from Alberta. So she has huge connections there. So I think that's why we were so successful is she was able to dedicate a lot of time and resources into the development and education. So it's been really well received.
Hey, Tracy, it's James Faturco here. I'm on
Oh, there
Amanda's.
you go. Hey, James.
I'm actually one of the transport nurses that takes these patients for EVT in Kelowna from Kamloops. So I can speak a little bit to that. It is a lot nicer when we can get them on the road without us quicker because our transport team can be in 10 different places at any different time and not actually be available to move these patients quickly if they're running TPA, which means they have to look at taking a nurse from the emergency department to go with the patient or delay the transfer. And with staffing levels kind of all over the province these days, it's a lot nicer to not have to pull another nurse from the department to send these patients. So that in itself is huge. And I think we're noticing differences in that kind of going forward here. So yeah, again, great that we can do this without the nurse transport at this point.
Excellent. Thanks. Any other questions, comments? Excellent. Well, thank you very much, Kimia.
Thanks for watching, everyone, and thank you for joining us on the BC chapter of the CACCN YouTube channel. We have a lot of great content from previous events we've had over the past 12 months. I would suggest subscribe and hit the notification button so you can know when the next thing is out. And if you ever want to come to our next event, we're on Facebook and on Instagram. Our links are listed below. And while I'm on the topic, if you're a critical care nurse anywhere in Canada, why don't you join CACCN? We have a ton of resources to help you be the best critical care nurse you can be. Go to caccn.ca and join us.